Assalamualaikum. Good morning to everyone, and I am Dr. Amanullah, Lail, Assistant Professor Pediatrics, Dow University of Health Science. Today we are going to discuss an important topic in pediatrics. The mostly mothers came with the history of vomiting after every feed, and baby is not baby is otherwise active, and baby has a history of the vomiting and spitting, preferred spitting. So you may diagnose one of the common problem that is known as a gastroesophageal reflux disease. So reflux disease diagnosis is important. In mild cases, the mostly patient having vomiting, but baby when gait and all these things become active, playing intermittently, and you just reassure the mom and guide them for the feeding. And if problems are not solved, then you should go for the treatment plan. So the main objective of our lecture today is first we start with the definition, then what are the pathophysiology, what are the symptoms of gastroesophageal reflux disease, what are the clinical manifestations, what are the causes of the regurgitation, vomiting in children, how you will diagnose, what is the treatment, prognosis, and about the complications. So the reflux disease that's known as gastroesophageal reflux GERD is the most common esophageal disorder in children of all age. Any symptomatic condition or anatomical alteration caused by reflux of noxious material from the stomach into the esophagus. Children with asthma, cystic fibrosis, developmentally delayed CP childs, hiatal hernia, and surgical procedure like repaired tracheoesophageal fistula are at increased risk of gastroesophageal reflux disease. So we will see this is the stomach portion, this is the esophagus, this is the lower part of the esophagus. Here, this is the lower esophageal sphincter, and that's the close. And if you would like to see here, this is the reflex, and the gastric contents are the regurgitate into the esophagus. So the failure of the cloyer or the reopening, transient reopening, could cause the reflex into the esophagus. And this is the diaphragm, the cruciate of the diaphragm, esophagus. This is the fundus portion of the stomach, and the regurgitation of the water, fluid, milk, whatever you take it to the regurgitate into the esophagus. So this is the gastroesophageal reflex. Lower esophageal sphincter is important, and it has intrinsic distal esophageal muscles, the muscular sealing fiber of the gastric cardia, the diaphragmatic aura, and transmitted the pressure of abdominal cavity, opening of this lower esophageal sphincter, and the regurgitation of the materials into the esophagus. Same over here, we see the picture. This sphincter is closed, and lower esophageal is, and here it is open, and the content from the stomach regurgitate into the esophagus. So the pathophysiology, the factors involved in gastroesophageal reflux includes the liquid diet, supine position, the short esophagus, small non-compliant stomach, frequent large volume feed, immature lower esophageal sphincters. So these are the factors, all these are involved in case of a gastroesophageal reflux disease. Nearly half of children have gastroesophageal reflux at 2 months of age. As infants grow, esophagus and stomach become compliant, solid foods are introduced into the diet, the upright position is attained, so reflux is stopped by the age of 8 to 12 months. So in mild cases, you have to reassure the parent, mostly the baby become normal within 1 year, or the reflex decrease when you will advise or add the solid food mostly from the 6 months onwards, and the frequency problem of the reflex solved. So transient lower esophageal sphincter relaxation is the major primarily allowing reflex to occur. The gastric distension, the straining, obesity, large volume, hyperosmolar meal, and increased respiratory efforts like coughing, wheezing, increase the reflex episodes, because in coughing usually the intra-abdominal pressure is increased and it causes the reflex. And it occurs in the obese as well, straining. If you will take the meal which is hyperosmolar, these all causes the gastric distension and the transient lower esophageal reflex, lower esophageal sphincter relaxation and GERD. So the same pathophysiology, and you see the certain bile reflexes which contain the bile, the gastric juices, and all these things. So it causes the erosions and all the acidity and all these things. So here, if a patient having hiatal hernia, it is also predisposing factors are impaired mucosal defense in the lower esophageal sphincter sites, peristaltics, and decreased esophageal clearance of acids, lying flat, alcohol, coffees. These are the other resources. Increased acid outputs in adults smoking, but in kids, the coffee and H. pylori infections are increased intragastric pressure and obesity or lying flats. Okay, decrease gastric empties. These are all the pathophysiology which causes the gastroesophageal reflux disease. So the symptoms of reflux or GERD, one is the esophageal and other is the extraesophageal. In esophageal symptoms, patient give the history of the irritability, the arching, failure to thrive, abdominal pain, chest pain. These are the symptoms. But in extra esophageal patients have asthma, laryngitis, sinusitis, chronic cough, hoarseness of voice. So these are the symptoms of the gastroesophageal reflux. Clinical manifestation, the most common manifestation of gastroesophageal reflux is esophageal disease. Sign of esophagitis like irritability, arching, choking, gagging, failure to thrive, abdominal and chest pain. Extraesophageal symptoms are age dependent. During infancy, there may be obstructive apnea, stridor, lower airway disease. In older children, airway manifestations are related to asthma, laryngitis, sinusitis. So the causes of regurgitation, the normal regurgitation, vomiting, ruminations, esophageal atresia, when the outlet, gastric outlet obstruction in case of the pyloric stenosis, bowel obstruction, cyclic vomiting syndrome, or psychological vomiting. So these all are the causes of regurgitations. And for the vomiting, you may rule out like gastroenteritis, food allergy, urinary tract infection may present with the vomiting, parenteral infection like middle ear infections, pneumonia, meningitis, appendicitis, poisons. So you rule out the infectious cause and non-infectious cause as well. Okay. Gastroesophageal reflux disease diagnosis is important after taking history. If a mother giving history of vomiting after feeding, and you listen the history, you will do the examination of the child or infants and check the anthropometry. If baby's height, weight is normal, baby is active, you just reassure. If a baby having failure to thrive and mother is worried regarding the health of the baby, then definitely you go for the diagnosis and thoroughly investigate the child. And usually diagnosis clinically, infants thrive normally on barium swallow. Free regurgitation of barium from stomach to esophagus occurs. So, for the diagnosis of gastroesophageal reflux, you will advise the barium swallow test. Okay, it is very important and helpful. Upper GI series may be needed to rule out the anatomic cause of vomiting, like esophageal atresia and all these things. The sensitivity test is prolonged monitoring of lower esophageal pH. It will be acidic if pH less than 4 due to the regurgitation of stomach content. As we know, stomach has a acidic pH. The esophageal impedance monitoring record the regular regurgitation of electrolytes rich gastric fluid into the esophagus. Endoscopy is used to evaluate the esophageal structure and anatomical anomalies. So the clinical examination, the barium swallow, check the pH and endoscopy. These are all the helpful for reflux disease. And regarding the treatment, the conservative treatment in mild case, the erect posture, the initiation of the solid feed may be curative. Frequently, the small feeding thickened with rice cereals, you have to add 2 to 3 teaspoons of the rice cereal and 1 ounce of milk. Placing the child in prone position and upright carried position with a elevated head end of the bed. Burp more frequently. Stick to a regular feeding schedule. Keep baby away from smoke. Avoid chocolate and beverage. So the diet modifications and just thickening of the milk will be the helpful, and give the small frequent feed and in erect posture, not in the patient baby should be lie in the supine position will be the helpful. If not treated with this treatment, you have to go for the surgical treatment. Surgical option is the fundoplication, the Nissan operation, combined with gastrostomy for feeding. Surgery is indicated in persistent vomiting with failure to thrive, esophagitis 2, or esophageal structure, apneic space, chronic pulmonary disease, unresponsive to 2 to 3 months of the medical therapy. In medical therapy, you have to go for H2 receptors antagonist. You go for the proton pump inhibitors like omeprazole, 0.7 to 3. Mostly we give the 1 milligram per kg per day before meals. The prokinetic agents which has capability to empty stomach like metoclopramide 0.1 milligram per kg before meal hasten the gastric empty and improve the esophageal motor functions. So first, diet modification, avoid the triggering effects like coffees, chocolates, and aid the medical treatment, the H2 receptors and antagonist, give proton pump inhibitors, prokinetics, metoclopramides, and feed in the erect positions and low. And gastroesophageal reflux disease, the prognosis. The prognosis is in normal infants is good, but less responsive to medical therapy is noted in if children is over 18 months of age, children with a large hiatal hernia or any anatomical anomalies, or neurologically CP child or handicapped children. So these children have a less response to the medical therapy. For the complications, common complication of the gastroesophageal reflux disease are dysphagia, failure to thrive, esophagitis with hematemesis, occult blood loss, esophageal structure, anemia, aspiration pneumonia, chronic cough, asthma-like attacks, and apnea. So if you have a BCQ for the complications, so these are the common complications you must keep in mind, memorize it. The dysphagia, failure to thrive, esophagitis with hematemesis, the occult blood loss, the esophageal structure, the anemia, aspiration pneumonia, chronic cough, asthma-like attacks, and apnea. So this is an important topic. I hope that you gain few important points from this. So you know the definitions, the clinical features, how we will diagnose, what are the investigation for the reflux disease, how we will treat the by medical, what are the medical treatment, what is the surgical treatment, what is the name of surgical procedure like a Nissan procedure, and what are the complications. So it is all about the gastroesophageal reflux disease and vomiting and regurgitation in the children. And thank you for your kind listening. So thank you very much. हेलो
हेलो जी सर।
जी हाँ, लेक्चर तो फिनिश हुआ। उनसे क्वेश्चन आंसर का कोई सेशन लें अगर कोई क्वेश्चन आंसर।
हाँ सर, ये देखें मोड में जाके चैटिंग का ऑप्शन है, चैटिंग ऑन कर लें अपनी। ऑन तो हुई भी मेरे पास से, आपके पास आएंगे जो भी सवाल
मेरे पास, मैं देखता हूँ अभी ऑन करके बोला है मैंने, देखते हैं।
हाँ, तारीख को बुलाइएगा। मोड है ना, मोड में देखें नीचे उसमें ना, उसमें आ रहा होगा मोड का ऑप्शन में जाएंगे ना, चैटिंग।
हाँ, मोड ऑप्शन आ रहा है सर, आ रहा है।
हाँ सर, ये इसको खोलें,
खोलो। थोड़ी देर के लिए यहाँ बैठ जाएं ताकि 2-3 क्वेश्चन जो है उनका रिप्लाई करें। Yes, so the esophageal gastric emptying, we can say that the gastric will be the empty. Okay, this is the main reason. You have to not esophageal impedance but gastric empty. It will help in the gastric. If gastric having distension stomach, it will regurgitate into the esophagus. Metoclopramide is usually we use in very important question. Usually we use the proton pump inhibitors and omeprazole. I have told you the dose is 1 milligram per kg per kg before the meal. It is helpful, but you can give the metoclopramide in severe cases as well. And I have already mentioned the dose. Okay, 0.1 milligram per kg. But you first go with the H2 receptors like ranitidine. But nowadays we encouraging the proton pump inhibitors, that is the omeprazole. So if you have any more question, you can email me. I will reply for that. Okay, thank you.
जी सर।
Sir, I have answered this question. I have my email. If I have any personal question or needs any presentation, I will be always thankful to them. Okay.
Okay sir. Allah Hafiz.
Allah Hafiz. Thank you. Thank